President, Colorectal Surgery Study Group, Chittagong. With the permission of the chair, I, Dr. Moinuddin Mahmood, Resident Surgeon, Chittagong Medical College Hospital, is starting this webinar. Am I audible to everyone? Is it okay? Okay.
Yes, you are.
Today's topic is colonic anastomosis, existing practices and new trends. In this occasion, I am profusely overjoyed to take the opportunity to introduce our panel of experts in this session. Professor Mohammad Shahadat Hussain, Chairman, Department of Colorectal Surgery, Bangabandhu Sheikh Mujib Medical University, has graced his presence in our session. He is one of the pioneer colorectal surgeons in Bangladesh. Our next expert is Professor Shahadat Hussain Sheikh. He is now working as Professor of Colorectal Surgery, Bangabandhu Sheikh Mujib Medical University. He is successfully operating colorectal malignancies laparoscopically for a long period of time. Our next expert is Dr. Mohammad Nur Hussain Bhuiya, Secretary General, Society of Surgeons of Bangladesh. Dr. Mohammad Nur Hussain Bhuiya is a young, energetic, enthusiastic surgeon working as Associate Professor and Unit Head, Department of Surgery, Shohid Sohrawardi Medical College. I welcome all the experts in this webinar. Respected audience, bowel anastomosis are common procedures in both elective and emergency general surgery. The anastomotic technique selected depends upon site of anastomosis, bowel caliber and quality, and underlying disease process. One important factor in the decision to perform a particular anastomosis, however, remains individual surgical experience and personal preference. The theory behind creating a safe, healthy bowel anastomosis remains constant irrespective of the technique chosen. Unfortunately, however, despite the perfect patient, healthy bowel and meticulous technique, some anastomosis continue to leak, resulting in significant morbidity and mortality. Studying different literatures, it is obvious that approximately 4% of all anastomosis performed after resection of a colonic tumor leak, and more than half of all postoperative deaths are caused by sepsis associated with anastomotic leakage. Decades of research have resulted in many studies investigating different techniques for constructing colorectal anastomosis in search of the safest method. Since the introduction of stapling instruments in the early 70s, one of the main choices open to the gastrointestinal surgeon is whether to create a sutured or a stapled anastomosis. Over the past 50 years with mixed results. Debates about the suture material to be used, suturing format, inverting versus everting sutures, single versus double layered suturing, interrupted versus continuous suturing, hand sewn versus stapled anastomosis, intracorporeal versus extracorporeal anastomosis, end-to-end versus side-to-side anastomosis still continues. Today, we will hear from 3 learned speakers about colonic anastomosis who have been performing this procedure successfully in their region for a long time. Today's speakers are Dr. Sarfaraz Beg from India. He will speak on anastomosis in right colon surgery. The next speaker is Dr. Deep Goel from India. He will talk on challenges in the management of low rectal cancer. The next speaker is Dr. Ronnie Matthew from Singapore. He will talk on robotic colonic anastomosis. I welcome all the speakers in this webinar. Now we will go to the session, scientific session. At first, I will introduce our first speaker, Dr. Sarfaraz Beg. Dr. Sarfaraz Beg is a renowned GI, laparoscopic, hernia, and bariatric surgeon. He is the director of Digestive Surgery Clinic in Bellevue, Kolkata. He has research publications in bariatric surgery, hernia, gallstones, colorectal cancer, acute pancreatitis, bowel intersusceptions, duodenal ulcer, biliary fistula, and complex anal fistula. Dr. Sarfaraz Beg has authored chapter on surgical nutrition, painful hernias, and he has written two monographs, one on CVD diseases and another on liver surgery. He is the author of the book Nutrition in Bariatric Patients, the only book of its kind in Asia. He will talk today on anastomosis in right colon surgery. I would like to request Dr. Sarfaraz Beg to share your screen and present the paper. Dr. Sarfaraz Beg.
Hello, can you hear me now? শুনতে পাচ্ছেন?
Yes, sir.
Okay.
You can continue.
All right. Thank you very much, Dr. Main. So I will not waste time. I have been allotted 15 minutes. I'll try to wrap it up in about that time. I bring the screen is not moving, just a second. Yeah, sorry, Amar. I don't know why this did not play. The slides were not moving. I'm going to share this again.
Yes, sir. You can share. Yes, it is visible now.
I will tell you. Sometimes in Zoom, what happens is you can't play it in the big screen. You have to work on the smaller screen. I will try this once more. If it does not happen, I will do it only with the small screen. Okay, but try this once more. Yeah, it's working. So thank you very much. Bring greetings from this beautiful hospital where I work. It's only 30 minutes on air travel for my friends in Bangladesh, and many of you have come to this hospital. It's a pleasure always to talk to my friends in Bangladesh. Today I will be talking on anastomosis after right colectomy. I will divide my talk into talking a little bit about theoretical aspect of a right colectomy, the different kinds of anastomosis, its pros and cons, and then I will talk about a little bit of a literature support of what is being practiced currently in the world. And finally, we will see a video. So most of the time when we are operating for right colon, it's either for tumors, which may be cancer, or intermediate tumors like neuroendocrine tumor, or it may be inflammatory lesions like tuberculosis or Crohn's disease. The anastomosis after the resection could be extracorporeal or intracorporeal. Traditional way was to do the resection, to do all the mobilization, then make a small incision either at the midline or subcostal. And this could be in various places based on surgeon's experience, preference, and also on the location, on the mobility of the mesocolon. But extracorporeal anastomosis was standard, and people thought, colorectal surgeons thought, that if there is got to be an incision for removal of the specimen, we might as well use that incision for anastomosis as well. It is simple to do. And this is exactly how we used to do. This is a proctocolectomy, after which I am taking out the entire colon from this incision and the ileum as well. And then I'm going to do an ileorectal anastomosis hand sew or staple. But this is what we used to do. And that's about 6-7 years back. Today, we would do most of these things intracorporeal. And you can see the phalansteal incision, which is low down. Now, why and what are the pros and cons of these different way of anastomosis. So the extracorporeal, which is a traditional way, the advantage is, since the logic is the specimen has got to come out from an incision, we make an incision, take out the specimen, and then use that same incision for doing the anastomosis. The advantage is it's technically easy, same incision is being used, and it's cheaper because we can either suture anastomose, we can staple anastomose. That's the major advantage of that procedure. And if it's a thin patient, even better. However, the disadvantage of the procedures are, A, there is a higher incidence of a longer incision. The incision tends to be longer if you were to do an intracorporeal anastomosis and take that out through a Fannin steel, which is the dilatable incision. The incision will be much lower. That's A. Therefore, since the incision is long, it can lead to wound infection, a hernia, and sometimes when we are doing extracorporeal, the incision, the surgeons tend to minimize the incision because they're considering this to be a laparoscopic surgery and the patient's expectation is to have a small incision. They make it very small. And we have landed up in where there was ischemia of the entire anastomosis. We have done that. And we have realized that this is because of the greed to do small incisions. So technically, we make it more challenging for us. And finally, in the obese patient, this is not an easy anastomosis to do. It's only easy when the patient is thinner. Fortunately, in cancer, they are thin, but not many of them. And finally, in many cases, they are not actually thin. They are obese patients as well. So intracorporeal anastomosis theoretically reduces the wound infection. The Fannin steel incision is dilatable. For a cesarean section, remember how the entire baby can come out of a Fannin steel incision. God gave us the perfect place to take out a baby because it's dilatable. And this incision is also, this anastomosis is also easy in the obese because we don't need to worry about taking the entire colon and the ileum out for anastomosis in a obese patient where the subcutaneous fat may be very, very high. Does the literature support this? Well, in 2017, there was a meta-analysis and a systematic review by Ustendorp where it was a pointer that intracorporeal anastomosis, these patients were having a faster recovery. That's all they could say. But this was picked up by this group, the Bolo and Targorona group, and they did a randomized controlled trial comparing patients of intracorporeal with extracorporeal anastomosis. And this is, in 2020, this was published, in March 2020, this was published, where they showed that yes, intracorporeal anastomosis patients have less pain and fewer complications in terms of surgical site infections and otherwise. This I found interesting and I have incorporated this. There's another randomized controlled trial which shows that the patients with intracorporeal anastomosis have less interleukin-6 and CRP, suggesting that probably this is far more better on the SIRS profile of these patients, and therefore they have less pain. In another study which looked at the leak rate between intracorporeal anastomosis and extracorporeal, they found that there was no higher risk of leak rate in an intracorporeal anastomosis. In fact, between the two groups, only smoking was a risk factor for leaks and nothing else. Let's go to the technique. And I think the surgeons would be, wanting to know about how we do intracorporeal anastomosis. I think some of you are already doing intracorporeal anastomosis. So I'm taking the example of a patient with carcinoid tumor of the appendix so that the surgery becomes less messy than a cancer patient. First, the patient position is supine with leg split. The camera and at times the surgeon can go in between the legs in certain steps of the procedure. Now, these are our port positions. And I would want you to carefully listen to what I have to say about why port positions are like this. A, U is for umbilicus. So the camera port 1, 2, and 3 represent the first 3 ports of triangulation, which is used for dissecting the retrocecal space. And that is continued right till the top, till we reach the liver. So 1, 2, and 3 are the ports which we use for developing the retrocolic space and also to divide the ileocolic vessels. So that is number 1. And number 4, 5, 6 the lateral ports on the left side are used for dividing the omentum from the colon. At times when you're doing extended colectomy, we may not remove the colon, but still we use 4, 5, and 6 for doing the surgery on the transverse colon and liberating it from the stomach or the omentum. That's how we do it. And third step, 1, 4, and 5 are used for middle colic and anastomosis. I am going to repeat this now because once I show the video, we may lose what is happening. We are switching from position to position. So number 3 is the camera port. 1 and 2 are working ports, and this is used for creation of the retrocecal space and division of ileocolic vessels. That's step 1. Step 2 is we take the camera in position number 5, and with 1 and 6, and sometimes with 4 and 6, we do divide the transverse colon from the omentum, the duodenum, and the stomach. Okay, so that's step 2. Step 3, we take the camera at port 4, and with number 1 and 5 working ports, we do the middle colic and the right colic. That's step 3. And the same port positions are used for doing an intracorporeal anastomosis. So camera at port 4 and 1 and 5 are used for doing the anastomosis. So I would want you to remember what I said, and now when you see the video, you would understand what I'm saying. And the last part is there is a phalansteal incision at the bottom, which you can see, which allows us to remove the organ through a wound protector, or we may endobag this depending on how big the specimen is. Usually it's a wound protector. Let's look at the video. So that is the carcinoid tumor of the appendix. We liberated that a little bit from the ileocecal fold. The first step, however, is to go at the point which is just behind the ileum, and we start opening up the mesentery at this point. Remember, our camera is at the suprapubic, and we are doing with 2 working ports. You can see these 2 working ports. The idea is to develop a plane. Yeah, you can see a plane is getting developed, and that is the plane which is between the retroperitoneum and the mesocolon. So the right mesocolon. First, we try to see the cecum, and then we come a little medially, and we develop the plane. You will see I'm developing the same plane without using any much of the energy source. We're just developing that plane. And nowadays, many surgeons doing right hemicolectomy. It's all about staying in the right plane. That is between the mesocolon and the retroperitoneum and the duodenum medially. That's it. Once that is done, this is step 3 now. What are we doing? We are liberating the transverse colon from the omentum. This is a carcinoid, and if it is a hepatic flexure tumor, we would probably take the omentum as well. We'll keep the omentum. So we are now releasing the omentum from the transverse colon. And you can see that the port positions are different. It makes life easier if we are using the right kind of port position. We can see exactly where we are. And now we're going to attack the middle colic and the right colic. But first, what we are doing is making the video. You can see the gallbladder peeping in. That window tells us that we have to now do all the dissection medial to it. So from the midline, now I take a hook. At this point, I don't use an energy source. I use a hook because it helps me getting right till the bottom till I see the pancreas, until I see the C loop of the duodenum. And on that, I try to search for the middle colic vessels. Okay, so now we are going to look for the middle colic vessels. Now we have dissected on the right. Now we come medially at the midline, and here we'll start seeing the pulsation and the bare body of the middle colic vessel. So now you can see that once we have taken this out, and in a very obese patient also, it is actually good to use a hook because it helps us doing millimeter by millimeter dissection, and that helps us in not missing the middle colic. Sometimes the middle colic can branch. That's the middle colic. It can branch early, it can branch late. The idea is not to clip the middle colic, but the right branch of middle colic. And you can see here that the middle colic has 2 branches, the right and the left. And we are now going to stay and clip the right branch of the middle colic. You can see it very well here. So now we're going to clip the right branch of the middle colic. Once this is divided, we will stay on the left branch of the middle colic and keep our dissection on it. So now that we have clipped it on 2 sides, we take a harmonic, the ultrasonic shear, which again is on a slow mode. So that's double security, the clip as well as the energy. So, and now we are making the plane, keeping the left branch of the middle colic as our guide. And once we have made a window right from this side to the other side, remember we've already cleared the omentum, so the window is going to be perfect. We are not going to reach the gastrocolic space. And now what we're doing, we're keeping ourselves on the left branch of the middle colic and going till we find the bare transverse colon. And then we're going to staple. There you can see the bare transverse colon. And now at this level, we're going to staple it. The reason why I'm showing this is the anastomosis will leak less if the vascularity is preserved. All this surgery is being shown just to communicate with the idea that the leak is dependent on vascularity, and knowing the technical aspects about what vessels to preserve is important. Now what we are going for is the right colic. It may be present, it may not be present. But in this patient, it was present. So you can see what we are doing is we are isolating this right colic, and this is so close to the, and this is a tricky aspect. This is aspect. You can see the pancreas and the C loop just beneath it, and this trunk is coming into the colon. We must be sure that this is going into the colon, and we're not taking away vessels which go to the pancreas or the stomach. And once that is done, we're going to divide it with a stapler, and now we go for the mesentery. So about ileocecal fold is being held, so you can make out that we are taking 6 inches, about 15 centimeters of the ileum. And then with proper retraction, keeping it perpendicular, we use energy source to divide the rest of the mesentery. So now we have completed the resection on the medial aspect, and all this is left with is the lateral attachment. And then once we have taken the lateral attachment, so this is the last part of taking the medial attachments. That's done. And now the entire specimen is hanging, the entire specimen of right hemicolectomy is hanging only with the lateral attachment. So some people have now innovated of keeping the bed at 90 degrees, and one can do the entire surgery from bottom up at one single go and using staplers all across. So that's another way of doing things, making things easier, but this is what we do. So now the entire specimen is parked above the liver, and this we will take out through a pan and steel incision. Now we wash the bed here to be sure that there is no bleeding. That's the duodenum, that's the pancreas, and that's the ileum and the colon. Now we're going to make it isoperistaltic. So we are cutting the colon about 8 centimeters from the staple line, and then the jejunum at the apex. So our tendency is to keep it apposed like this rather than the antiperistaltic way. So this is what we do, although it doesn't probably make a difference. And then we fire a stapler here, depending on the thickness, but mostly we use a purple or a blue stapler. And then the trick is this anastomosis. What we do is we start from two ends. We do not try to do this as interrupted or anything. In a right colectomy, unlike the left side, we have got ileum, very good vascularity. So we use 20 PDS, and we start from inside. The knot is inside from one angle, and then we keep on going with, this will be a single layer anastomosis. We try to take not the mucosa of the colon, but we don't stress about it. In the jejunal side, we definitely take full thickness. And once this is done, we start from the other side. So this is how intracorporeal anastomosis is being done. We start from the other side with another 2 PDS. And you can see what we are doing is we are securing the angles. These are the areas which leak. So if we secure the angles, they will be better and more secure. So here we are now proceeding from 12 o'clock till 6 o'clock. Initially, we started with 6 o'clock and went till 12 o'clock. Now we're starting from 12 o'clock and coming to 6 o'clock, and we'll tie the knot in the middle. As you can see, we're avoiding the mucosa on the colon side, and you can see that we are taking the full thickness on the ileum side. So once that is done, this anastomosis is looking pink. It is looking well, good in color. There is no tension anywhere, and it's lying flat. Remember the port position, as I've shown you earlier, it's very important for comfortable suturing. If you try to suture from non-ergonomic ports, it will not be this simple. So we have not compromised on port positions when doing intracorporeal anastomosis. Initially, we used to. Later on, we realized it's just not worth it. We might as well put in extra ports to make things easy. Now, for the mesenteric closure, now there are some confusions whether we need to close or not because such a large gap. Our policy is to close it whenever possible. And the most important thing is to use what we do is we use a knot at the one end so that we don't have to ligate it, just to make life simple. Although again, putting in a knot out there would not be difficult. And you can see what we have done is we have closed the entire space from bottom up. We can use barbed sutures here. If you have barbed sutures, they are better for this purpose. Following is not a problem. And we have used silk in this patient. And then ultimately the specimen is retrieved in a bag or a wound protector via fan and steel incision. From this talk, for all colorectal surgeons, what are the take-home points? A, anastomosis after right colectomy can be extracorporeal or intracorporeal. In a thin patient, it won't make a difference. For an obese patient, intracorporeal will make a difference. It will reduce wound morbidity. It will lead to faster recovery, less hernia chances, so and less pain as well. So making it intracorporeal, especially in obese, is important. So we have thought that yes, for us, all anastomosis should be intracorporeal. And if you look at the literature support, it supports intracorporeal anastomosis. Even the video that we showed you, the idea is to show that it is possible to do it. And once the specimen has been isolated, it's a linear structure. The maximum width of the wound would be the maximum width of the tumor that we're dealing with. Many times this would not be great, but if you try to take it out from a separate from an incision and do extracorporeal anastomosis, it will be wide. So yes, literature supports it, even our experience, and we have stopped doing in many cases extracorporeal anastomosis. We use intracorporeal most of the time, especially in the obese. Thank you very much. That is all from my side. I will stop my share and hand it over to our chairperson for the rest of the proceeding.
Moin, switch over to next.
Okay, I'm here. Am I audible?
Yes.
Yes, Dr. Mahin Bhai, you're
Okay, thank
audible.
you, sir. Thank you, Dr. Sarfaraz Beg, for the nice presentation and excellent demonstration of right colon surgery. Now we'll go to the next speaker, Dr. Deep Goel. Dr. Deep Goel is currently working as the Director of Surgical Gastroenterology, Minimal Access Surgery, and Pediatric Surgery at the BLK Super Specialty Hospital, New Delhi, India. Dr. Deep Goel has an impressive array of academic achievements. His articles are published extensively in national and international journals. He is in the editorial board of Indian Journal of Coloproctology, online journal Grand Rounds, and peer reviewer in South Asian Health Forum. Dr. Deep Goel has been conferred Best Doctor Award by Indian Medical Association and Heart Care Foundation of India. He will talk today on challenges in the management of low rectal cancer. Now, I request Dr. Deep Goel, please unmute your
Is my
microphone.
screen, is my slides visible?
Yes,
Am I
sir.
audible?
Yes, sir.
My
Audible.
slides are visible?
Visible, clear.
Thank you very much for inviting me for this talk. And in next 15 minutes, I'm going to talk about what challenges we face in management of low rectal cancer. I'm not going to focus on the technique and the video because Dr. Matthews is going to talk to you about how do we do low anterior resection robotically. So I have no conflict, nothing to disclose. Well, the history of rectal cancer surgery is very illustrious and started from Sir William Miles, who described abdominoperineal resection, to Gerald Buse in 1983, who first demonstrated TEM, which is a local excision, endoscopic local excision for early stage rectal cancers. And in between, we had Golliger, Dixon, Bill Heald, Parks describing various techniques. Laparoscopic colectomy was first described in 1991 by Jacobs, and it was published in Surgical Endoscopy. But soon after he published it, there were a lot of concerns to apply laparoscopic surgery for colorectal cancers, port site metastasis, recurrence of disease, steep learning curve, conversions, training and skill development, and obviously cost. Gradually, in the next decade and a half, all these concerns were erased by doing a lot of good trials. When we talked about port site metastasis, in the early reports, they reported around 21% episodes of port site recurrence, which was very, very scary. And this actually, delayed the progress of laparoscopic surgery into colorectal cancer. Various trials were initiated: COST, Color, Classic 2, Barcelona, LAFA, Hong Kong, Color 2. Most of these trials were actually non-inferiority trials, and they really clearly demonstrated that laparoscopy is equivalent to open surgery, especially for rectal cancer, if not superior. So what was the game changer today in rectal cancer treatment? As we know that the most challenging part of rectal cancer treatment is to preserve the sphincter. Whatever we can do to preserve the sphincter is something which is desirable. And in the early parts, even if the tumor was 5 to 6 centimeters from the anal verge, the abdominoperineal resection used to be the standard technique. But as we grew, as more and more advancement in the neoadjuvant treatment, diagnostic treatment, technology happened, the game started changing, and we were able to save sphincter more and more. So neoadjuvant treatment, proper staging by MRI, the techniques of sphincter preservation by doing intersphincteric resections, staplers, energy sources, and use of indocyanine green. These were some of the factors which came into play. Looking at the indications of neoadjuvant therapy, we all know that there is some difference between the Western world and Asian countries. And but most of the times, to teach our students early cancers, which are T1, T2, upfront surgery is what is recommended. Late T3, T4 is neoadjuvant treatment. There is still some confusion and gray areas in late T2 and early T3 rectal cancers. In the United States, late T2, early T3 may go for neoadjuvant treatment. In United Kingdom, this may go for surgery. So obviously, individual institutional policies will play a role. Couple of slides about contrast enhanced MRI pelvis. Well, MRI pelvis is the single most important investigation for local staging, and in a Mercury 2 trial, very clearly state what do we look at the MRI? It is very, very important for a surgeon to know that when you are going to a radiologist, what are you really asking him? So we must know the depth of the tumor, height of the tumor, nodes, the size of the node, shape of the node, irregular border, mixed signals, extramural venous invasion, CRM, and the mucinous content. All these have a prognostic implication in our management. Once you have decided for a patient to undergo a neoadjuvant treatment, what you do is a YMRI, which is called post-treatment MRI, and it very clearly tells you the response and also the amount of viable tumor. We really, measure it by a magnetic resonance tumor regression grade, which is called MRTRG. And I'm not going to go into the detail of this. We classify them into low risk and high risk. Again, this was shown by Gina Brown in Mercury 2 trial. Another controversial topic happens is that when should we do the surgery after neoadjuvant treatment? Well, classically, we were told between 4 to 6 weeks, but as we have grown in experience and more literature is available, now the accepted interval between the finishing of neoadjuvant treatment and before we do the surgery is between 8 to 12 weeks. And that is because we believe that the response of the radiation is happening until very late. So between 8 to 12 weeks in our department, we normally do it beyond 10 weeks. And that is what is the recommendation today. Another controversial point is how much distal resection margin is required for colorectal cancer. Well, it is classically taught that 2 centimeter rule is accepted and adopted. But as we understand oncological benefits of neoadjuvant treatment, distal margins are shrinking, especially in good biology tumors. At present, 1 centimeter margin post neoadjuvant treatment with favorable pathology is most accepted. Sub-centimeter margins are not recommended out of research protocol. But if patient is insisting, any margin which is negative is acceptable. If patient does not want an abdominal perineal resection, any negative margin is acceptable. Intersphincteric resection, again, as I was saying, to gain more length into the sphincter, to save the sphincter. Intersphincteric resection is again a very useful thing. But most of the times after doing intersphincteric resection, you will require a coloanal anastomosis. And some robotic techniques and laparoscopic techniques will also gain little more length into the pelvis. Circumferential resection margin, as we all know, is an independent risk factor for local recurrence and poor prognosis. And MRI is the best investigation to know whether circumferential resection margins are involved or not involved. Even if there are threatened margins, we will need to give a neoadjuvant treatment. More than 1 millimeter clear margin is ideal, and less than 1 millimeter indicates poor prognosis. Well, this does not apply to the lower rectal cancer, so I will skip this. Another good thing is that today, the quality of surgery can be measured. It is important that a pathologist measures the quality of specimen, quality of surgery. So they can actually quantify the quality of surgery by looking at the TME specimen. And how they say is whether the mesorectum is complete, or it is near complete, or it is a poor specimen. So if the mesorectum is intact and smooth, there are only minor irregularities, there is no defect more than 5 millimeter, it's a complete mesorectal excision. If there is a moderate bulk in the mesorectum and there is an irregularity, but there is no muscularis propria which is visible, it is a near complete. And poor specimen would be having very less mesorectum. The mesorectum will be very irregular, and you can visualize muscularis propria. So it is a good thing that, we are constantly under the watch, and a pathologist can actually grade the kind of surgery we have done. As my friend Sarfraz was saying, that we have to have a almost foolproof anastomosis, and for that we must have a well vascularized and tension-free ends. And tension-free ends can be achieved by adequate mobilization, and we will see that in next slide. That this is a very interesting study published. This was done in animals, in cadaver actually, and it very clearly shows that if you mobilize partially, what you gain is a 46 centimeter length of the left colon, and if you mobilize the splenic flexure partially, you will get 57 centimeter, and if you fully mobilize the splenic flexure, then you get 85 centimeter of the length. So there is a clearly you can see that there is a benefit of mobilizing the left colon if anastomosis is under tension. Couple of slides about ICG perfusion. See, whenever we are doing an anastomosis, we need to make sure it is a well vascularized, and by using indocyanine green, you can see whether there is a good vascular supply to both ends. And the right side where it is green, you can see that when we do this on infrared mode, that both the ends are well vascularized. This is a multi-centric phase 2 trial, which is a prospective trial of 504 patients. ICG used and not used, there were two groups, and the leak was 2.6% in the group where ICG was used, and it was almost double in the patients where ICG was not used. So that is very interesting. And in this particular study, in 5.8% of the patients where there was no leak, the bowel division line was changed in patients where ICG was used. So in fact, 5.8% leaks were prevented by changing the line of division. So this is telling us that it is here to stay. Another point of debate is whether we should take the inferior mesenteric pedicle at origin or after giving the left colic vessel, which is called high ligation and low ligation. Well, until very recently, we used to think that high ligation close to the origin is important for oncological safety, but it is proven that it does not give you any benefit if you have taken out all the lymph nodes from the origin and you ligate the vessel low. So this is again a retrospective study which shows that colonic ischemia and anastomotic leak are more in high ligation group. Urinary defecatory function scoring is better in low ligation group at 12 months and 3 months. And splenic flexure mobilization was performed less frequently in low ligation group. So what it is clearly showing us is that if you do low ligation, the functional outcome is better and you may not need to mobilize the splenic flexure. High-low trial is a very famous trial. Again, what it shows is same thing, that in low ligation group, continence, obstructive urinary symptoms, and sexual function is better, though there was no high risk of anastomotic leak in high ligation. So again, there is some merit of preserving the left colic vessel and then ligating IMA pedicle for better functional outcome. Again, while you're doing the surgery, it is important to look at the key areas where the nerve injuries can happen. And this is one at the IMA root that you have to be careful. That is why you need to go little higher up, not flush with the origin. This is superior hypogastric plexus where the nerve is there. This is the right hypogastric nerve. One has to be careful here. Again, inferior hypogastric plexus, close to the seminal vesicles, all the nerves coming in from laterally, lateral dissection. Coming to another important point, which is special situations. We deal with a lot of obstructive left-sided colorectal cancers. What you can do is, so again, the classical way is to do a laparotomy, do a stoma, do the excision, and then do a revision surgery. So the disadvantage is that you will have a laparotomy, you will have a repeated surgery, you will have fecal soiling, you will have incisional hernia, longer hospital stay, and a stoma. If you do a stenting of these tumors and then do an elective surgery, so you are converting in an emergency situation to an elective surgery and then doing a laparoscopic surgery, you can get away, you might get away without doing an stoma and repeated surgery and avoiding the all disadvantages of laparotomy. Colonic anastomosis, as I was saying, if you are doing an intersphincteric resection, you will do a colonic anastomosis. Functional outcome is often criticized. Quality of life issues are there. It should be done only in high volume centers where there are specialized physiotherapy centers and proper counseling is available. Stoma versus no stoma in low rectal cancer is always going to be a debatable issue. In our center, we always do, most of the times I would say we will do an stoma because more than 90% of our low rectal cancers have already received neoadjuvant treatment. This is a randomized multi-center trial published in the Annal of Surgery, total 234 patients, divided almost into half-half, and there was an anastomotic leak of 10% with stoma and around 28% without stoma. And reoperation rate was again higher without stoma. So this study seems to suggest that defunctioning loop stoma decreases the rate of symptomatic anastomotic leakage and is therefore recommended in low anterior section. Coming to conversions from laparoscopy to open surgery, again, it's a debatable issue. It is usually, patients who are very difficult needs conversion, either due to the bad disease profile or inexperience of the surgeon. Again, in conversion, we have, the literature is very clear that leak rates in converted patients are higher and even the complication rate is higher. A word about complete clinical response. This is a, newer concept where if there is a complete clinical response, you can, these high-risk patients who do not want abdominal perineal resection can be put into a group called wait and watch. And this was first proposed by Angelita Habergama from Brazil in 2009. And they showed very good results. At this point of time, they are normally not done outside the research protocol. I, at the moment, have around 7 patients who are on complete clinical response protocol, and we watch them very carefully. You must mind that these are the patients who are willing for a very, very close follow-up and at high risk for surgery, and they do not want permanent stoma. So I would like to end my talk by saying only a fool learns from his own mistakes. The wise man learns from the mistakes of the other, and we must do that. I am learning all the time. Tombstone will be my diploma. And all these complex surgery cannot be done alone. A good team is necessary, and together everybody achieves more. Thank you very much.
Thank you, Dr. Deepgwell, for your nice and informative presentation. Now, our next speaker, Dr. Ronnie Matthew. I will say a few words about Dr. Ronnie. Dr. Ronnie Matthew is now working as a senior consultant, Department of Colorectal Surgery, and Director of Research at Singapore General Hospital. He is also working as clinical assistant professor and research mentor at Duke's NUS Singapore, and clinical senior lecturer, Yung Lo Lin National University of Singapore. Dr. Ronnie Matthew is a member of Robotic Surgery Board at Singapore General Hospital. He is also a member of specialist colorectal surgery societies, both nationally and internationally. One of his projects on artificial intelligence in colorectal cancer risk prediction was recently awarded as one of the top 10 most impactful projects at the Singapore National Health Tech Challenge 2018. Today, he will present on robotic colonic anastomosis. I request Dr. Ronnie Matthew to present his paper. I think Dr. Ronnie Matthew is not online.
No, I can't see him in the
Yes,
participants group.
yes, he's not here.
Had he joined earlier or he not joined?
He's here. He's here.
Is he? Okay.
He's here.
Dr.
Can you hear
Sanaullah
me?
probably can.
Ronnie?
Yeah, can you hear me?
Yes, we can hear you, but we cannot see you, sir.
Can you see the screen now?
No, the screen is also not visible, Dr. Rani.
Okay.
Just share screen.
I tried that. Let me just try again.
Okay.
How about now?
Yes,
Yeah.
screen is shared now. Hi, okay.
Okay. Let me see whether I can move the. Okay. Good evening, everyone. Greetings from Singapore and Singapore General Hospital. Can you hear me well?
Yes,
Yes.
loud and clear.
Okay, yeah, great to be here. Actually, it's an absolute great honor. I've been to Bangladesh a couple of times in your scientific committees, but the meetings, association meetings, and it's a privilege and honor to present again. And I thank the chairperson, Prof. Shelley, and also the expert panel and the organizing committee. Thank you. I had a few days notice for this. Unfortunately, I'm not talking, only some of it is on anastomotic aspects. I think it's better to keep it to the discussion. I will talk more about it, but I just primarily going to talk about the role of minimally invasive surgery in colorectal cancer, laparoscopic, robotic, and transanal endoscopic. I've got several slides, so apologies if I'm rushing through. No disclosures. So, like I said, laparoscopy, robotic, transanal endoscopic operation, and anastomotic aspects and considerations. Laparoscopy, as you all know, multiple ways of doing it: conventional multi-port, single port, complete mesocolic excisions, nodes, transanal TMEs. Just quickly going through it, actually. It's first since 1990, the early series in 1991, initially thought to be technically challenging, time consuming. People didn't like it particularly, but they started to see some benefits of it: decreased pain, ILS, and decreased length of stay.
Sir, I beg apology, Ronnie Matthew, sir. Please give the slideshow mode.
Okay, 1 second. Let me just see whether I can. Is that better?
Yes, sir. It is okay.
Okay. Okay, so the main problem with the laparoscopy in the initial bit, people were worried and reluctant to do it. Apart from the technical challenge and the instruments and the screen and the stack, technically there was issues and it was not designed to do it, but people could see the benefits. But the main oncological worry, I'm talking only about cancers now, is that there was up to 21% of port site recurrences, and this was really worrying and people didn't want to do it. Whether this is not the case just with advanced or early cancer. Subsequent trials shows that it is much less. Then started the big trials, 55 in each arm by Cleveland Clinic. Basically, they showed significantly less opioid use, better bowel function, better respiratory function. Then Lacey from Barcelona published or undertook another trial of 219 patients, single center, two surgeons. Basically, again, similar results: better bowel function, length of stay, lower morbidity, better recurrence, lower overall survival, better, and it is showing that it is better. Then came the 2 or 3 landmark trials. One is a cost trial from Heidi Nelson from US, basically large trial, 872 patients, 48 centers. You can see the numbers. It's a huge trial, 400 plus cases in both sides, 5-year follow-up. Main thing was oncological, time to recurrence. Obviously, they showed, as expected, better analgesia requirements, shorter length of stay, similar morbidity, but the main thing they were looking for was the survival and recurrence was similar between open and lap. And the wound recurrences were, whether open or lap, similar and less than 1%. So that put to bed the issues with port site recurrences. and they said concluded that it is safe to proceed with the laparoscopy. Then the landmark classic trial published in 2005, mainly UK centers, 27 centers. They looked at colon and rectum, multi-center, again huge numbers, 2:1 randomization, shorter stay, but the conversion rate was 30%. There were more complications in the converted case. We can debate about it, but it's obviously difficult cases, not because they're converted, but it was difficult to do whether it's open or lap. So, and it's understandable that complications are more. Equivalent morbidity and mortality, but the main issue with that trial, not issue, but one of the results, striking results, was the rectal margin, radial rectal margin positivity in the lap rectal cases, which is much higher. So they recommended that colon it is okay to use, but rectum don't use laparoscopy. This was the landmark 2005 paper. As a follow-up of this, as part of the study group, we published on the long-term complications of the quality of life from the classic trial, which shows that the long-term outcomes are not so good if you have complications. That's across the group. Then the color 1, 2, and 3, it's a European trials. Again, huge trials. 29 centers, 600 odd cases in each group, 90s. By then, the learning curve is, as you know, people have traversed the learning curve. 17% conversion. Again, good immediate and short-term functional results, and the complication rate being better with the laparoscopic group. Basically, they said lap is safe for colon cancer. Then the Koreans came up with their trial. Basically, only 3 centers, 170 cases each, but you can see the conversion 1.2%. And you can believe it. I spent 6 months there, and I haven't seen a single open case. And you can, a very talented group of people. The laparoscopy again shows good results. No difference in the CRM rates. Unlike the classic trial, TME quality all good. So basically, they're saying even in post-neoadjuvant or bulky or mid to low rectal cancers, laparoscopy is safe, better short-term, and equivalent oncological outcomes for rectal cancers. So this shows that if it is done well, it is good. Again, the rectal cancers from for the another trial, 1,044 patients, basically shows similar results at 3 years. And lastly, the color just came out, or not just came out a few years ago, shows that at 10 years, there is no difference in overall survival, long-term survival, recurrence, etc. So laparoscopy is safe. But obviously, there was, I didn't include it, there were 2 recent trials in the a la carte and the American trial, which published in JAMA, which shows that the rectal cancers, it is slightly inferior, the laparoscopic. And I presume we can discuss, if you have time later, why that is the case. So these 2 trials have thrown spanner into the works for rectal cancer for laparoscopy, and they compared that with the open versus laparoscopy. So 2 trials done by experts. Professor Dr. Deep mentioned about stenting. We just published it, but basically stenting is good, but there is some oncological concerns of the long-term thing, but it basically makes a emergent situation into a more elective setting. So there are clear benefits, and one of the clearest benefit is decreased trauma formation, including the landmark CRUST trial from UK, and also increased laparoscopy. Our own series in Singapore, despite the stenting, we managed to do 50% of the cases laparoscopically from our own center, and the trauma rate is less than 10%. So clear benefit, but we are seeing some increased recurrences, long-term recurrences in the stented group. We are not sure why. There may be some microperforations, etc. Now, robotic is used for obviously colonic, rectal, pelvic lymph node dissections, excenteration, pelvic excenteration. The main issue is the cost. Multiple studies have shown the cost, but the oncologically is same or maybe better, but the cost is the issue. Multiple platforms, and it is all single monopoly by Intuitive Surgical. They buy up every other company, but now Medtronic has come out and they are doing early trials, early clinical trials from this year or early next year. I think the FDA is coming out soon. So the monopoly is ending, and the J&J along with Google is doing. Koreans have launched their own robot, and there's robots from Europe and UK. So watch the space. I think it's the cost is going to come down. That is only limiting factor for the robot actually. I'll just briefly talk about a robotic technology, which is basically surgeon is seated at the patient console. He controls the robotic instruments. Endo-wrist moves, and it's like a wrist, allows basically increased dexterity, maneuverability, accuracy, and precision, and is a magnified, and it's a 3D view. So it takes away that 10% up to 10% tremor if you have it. So multiple advantages. The main advantages is in a tight space. Obviously, cost is an issue, and because of the 3D, there's a hand-to-eye alignment, natural intuitive movements, etc. And careful design is possible, but irrespective of the approach, open, laparoscopic or robotic, the operation is exactly the same. It is just that how you manage to do in tight spaces, what is the best thing. And sometimes I feel whatever approach, rectal cancer can be difficult, but robot, I think it is gives definitely a superior operation and results, in my own personal opinion, and based on a lot of other trials. Evidence, just briefly, I can skip through the slide. First came in 2002. SGH, our hospital, performed in 13 years ago. Multiple trials, basically all showing the CRM is slightly better with a robot compared to thing, and short-term advantages for robot. But these are single CDs or case matched, etc. Meta-analysis showing reduced blood loss, reduced complications, etc. Again, same, multiple studies showing some conversion rates. And I'll just quickly, this is the important bit for urogenital dysfunction. Trial shows that there is a benefit for doing robot compared to laparoscopic, because better nerve preservation, possibly because of tight spaces, better magnification, and better control of the instruments, as opposed to laparoscopic, which are long, straight instruments, difficult to maneuver in the low rectum. And the recent not recent, few years ago, again, a difference. I'll just quickly go through the slides, just interest of time. This is the landmark other trial, ROLA trial, published a year and a half ago by David Jane and group. Basically, they wanted to compare, this is the biggest multi-center randomized control trial. In fact, the only trial, randomized big trial for robot versus open. So 29 sites. The surgeons were experts across for laparoscopy and robot. 471 patients, robot 237 patients, and laparoscopy 234 patients. Outcomes, the primary outcome was conversion to open laparotomy. We can debate whether that was a correct outcome to do, because it's not the conversion people are worried, it's about the quality of the oncological TME quality. So, but anyway, they included that in the secondary outcomes, urogenital dysfunction, oncological TME quality, and post-op complications. They were not powered for this, but it mainly powered for the conversion to open laparotomy. Results, 64 mean age, males more 70%, 98% completed the study. Overall conversion across both groups was, across the robot group was 10%. CRM positivity was 5.7%, but there's no significant difference in any of the other intra post-op complication, plane of surgery, mortality, bladder dysfunction, sexual dysfunction. Basically, they showed that the conversion was bit more in the laparoscopy group, 12 versus 8, but did not reach significance. And similarly, the CRM was more positive in the laparoscopy group, 6 versus 5, but again not reaching significance. Basically, they concluded that it is suitable for rectal cancer. It is not inferior, and in good centers, good thing. It is good, but it does not offer advantage in a rectal cancer resection. But the subgroup analysis shows that in males, obese, low rectum, it is definitely advantageous. But they were not powered to do it. But so basically, the issue was the powering of the study, looking at only conversion. But for like I said, males, obese, and low rectum, it is advantageous. And on a personal note, I think it is definitely, it makes a huge difference for rectal cancer. Rest of the colon, not really, it is a cost, although you can do it, but for rectum, it's a different ball game. Transanal operations, I don't think I have time, but basically you can do very early rectal cancers provided the patients have been consented. Transanal endoscopic operations, either with different platforms, transanal endoscopic microsurgery, transanal endoscopic operation, or TAMIS. Different manufacturers do it, but basically for very early rectal cancers. But the main thing to note is the lymph node is not removed. It is just a local excision. So these are for T1 cancers at the most, but primarily indicated for benign, but up to the whole of the rectum, you can up to 15 centimeter you can do, but there are some technical challenges. But if it is for frail elderly, it is not unreasonable to consider. It avoids a morbidity of a major APR or an ultra low anterior resection. So something to consider, but with full counseling of these patients. Recurrence rate, local recurrence rate is only marginally higher, 5 versus 7% for the transanal operations. I don't have time to cover the endoscopic mucosal resection and techniques in Flex Robot, which is the newest sort of kit in the armory for transanal operations. Okay, mainly just I realized later on that it's mainly about the anastomosis. So I just quickly just did a couple of slides, but I just it's very obvious to everyone, but I'll just go through it. It's basically it's been covered very well and shown very well by Dr. Baid, and also talked briefly by Dr. Goel. Different ways of doing it, side to side, side to end, end to end, isoperitoneal, linear, etc. Rectum is the issue, whether you do a straight colorectal anastomosis or colonic J pouch, the CJP, or coloplasty. Coloplasty is outdated, so issue is straight colorectal anastomosis or J pouch. The J pouch does give some benefit for the first 9 to 12 months. After that, it doesn't. It equates same, but remember that there is a stoma covering this for the first 3 to 6 months, depending on the chemotherapy. So the role of J pouch is, not much time is there to enjoy the benefit. Actually, maybe it's a false dawn. I personally do a straight rectal anastomosis, open or MIS, intracorporeal, as shown by Dr. Baig. So main thing is ICG, again shown by Dr. Goel. It is shown to decrease reoperations, anastomotic leak, change the plane of dissection or resection of the colonic end. Whether we should do a check endoscopy at the end of it, and whether we need a covering stoma. These are only for rectal things. I'm talking about drains and anal decompression. I just briefly tell a few things. One is ICG. I think several studies shows the same thing, but there are some caveats and considerations to make, and it's not be blindly followed. Check endoscopy I do for some of my minimally invasive cases. It is good to do the leak test and do the mucosal ischemia and do the staple line integrity and to see if there's any bleeding from the staple end. So these can be managed straight away. So it has some benefits. Obviously, some logistical issues. Covering stoma, obviously, everyone, I think most of us will do for low rectal anastomosis or radiotherapy, etc. Drains I routinely place, even though we follow ERAS, I do routinely place, and I also do a transanal rectal Foley. And there are several studies showing that if you reduce the pressure within the low rectum, and it has a effect on, in my opinion, lower leak rate. But we can talk about it, why that is the case. This is the largest meta-analysis just published two months ago, shows that basically 4,000 patients, they looked at it and they said that basically it reduces the leak rate. This just came out, and reoperation overall complications. Then some other things. CC for colorectal anastomosis, basically they are in keeping with the anal decompression, putting a sort of a seal intraluminally, transanally. And this is how it looks actually at the end, but these are early stages. It's I think it's from Germany. But for the anastomosis, I feel that whether intracorporeal or extracorporeal or laparoscopic or open technique or whatever way, absolute parameters is patient selection, in the sense that should we do an anastomosis or should we not do anastomosis. It depends on the thing. Optimization as much as possible. In my opinion, it's very crucial in nutrition, etc. In-drop, these are standard, historic things, but it still holds true. Of all these things, to me, the two main things is tension-free and good blood supply. This is where my problem with, no, ICG is good, but the blood supply is the only thing. ICG looks at only this, but there are several other things, and sometimes you get a false sense of positive thinking. It's all okay. I mean, there are various others to think, tension and blood supply. I put it in red. That is the two biggest factors, in my opinion, which cause anastomosis apart, and which we can alter it. We can modify it. Anastomosis is stapler most of the time, so it is only as good as the fool who fires it. So it's fail-safe things, especially with the motorized ones. And so main thing is tension-free and good blood supply. As Dr. Goel was showing, that if you mobilize a splenic flexure, which I do for most of my cases, it makes a difference for the tension. Check anastomosis, I talked about it, whether we should do a scope or not. I do, not for my open as much, but for lab, because I think it's better, because you can see open, you can see anyway. Leak test, I do. Donuts, consider drains, I routinely do, and stoma depends. Post-op usual CRP has been shown at a 98% accuracy that if it's below a certain cutoff, leak is ruled out. But we did our own CTs in our hospital. Maybe the accuracy is not so high, maybe 70%. But main thing is to have a low index of suspicion, act early, do a CT scan, and act early and early intervention. So that ends my presentation. And if we have time, I can show you a little bit of a robot. I'm not sure whether you have a time or not. Do we have time for a robotic video or not?
Okay, sir. I think you can show the video.
Okay, let me just. Okay, can you see?
Yes.
Okay.
Yes, Matthew.
Okay, 1 second. Okay, this is it's not on anastomosis, it's on a robotic APR done transabdominally. You divide the, rather than anastomosis, I thought this may be a better video. Transabdominally, you do levator and eye division. So this is IMA. I just skip through it in interest of time, if you don't mind. It's just IMA, then it's the vein taken out, and it's a medial to lateral mobilization, standard medial to lateral over the gerotas and lateral side. Then these are the lateral dissections, and this patient had a previous hysterectomy, so we had to do some dissection. This is the posterior rectal dissection coming into way. This is what I was saying about the tight anal spaces. This is still laparoscopy very good, but once you get obese patients or males or narrow pelvis, becomes very difficult, because this the third arm gives you the extra traction, and it's and the views are really fantastic. Obviously, cost is an issue. So we in our hospital, we only reserve robot for rectal cancer, because we see the benefit only in that, comparing the cost. Because the rest laparoscopy is equally good. So this is all the way down to the pelvic floor. This is the anterior part of the low TME is being dissected out. This is almost coming up to the sphincters now. So this is the levators, which we are dividing it transabdominally. Normally the classical way is perineal dissection, either supine or prone, but here we can customize the defect in the levators transabdominally, meaning where the tumor is, you can take out more. You don't need it to do it blind from bottom up. Obviously easier said than done, but more easier in women, like in this case. So the pelvis is wider, but if you can do it, it's very good. It's basically you go straight to the ischiorectal fat, and all we need to do from bottom is make a skin cut, ischiorectal fat, and you're there. The only difference is anteriorly, you still need to dissect, because we don't do this anteriorly. The low vagina and the prostate, we still leave it to be done on the traditional way. I'm just speeding it through, interest of time. So I've just sped it through. This is from the bottom. You're already into the cavity there. Almost done. Yeah, and then you just take it out through the bottom, and then you close it, and then that's it actually. So that ends my presentation. Hope I didn't exceed. Yeah, I finished.
Okay, thank you, Dr. Matthew, for nice demonstration of robotic surgery. Dear respected audience, we are very happy to announce that some of our senior teachers are here. Welcome. I would like to welcome Professor Margul Hussain sir, Professor S.M. Ashraf Ali sir, and Professor Anwarul Haq sir. We will surely hear something from them. Now we will go to the panel discussion session. This session will be moderated by Dr. Adnan Bacha, Assistant Professor, Southern Medical College Hospital. Dr. Adnan Bacha. I think he will surely raise some scientific issues here.
Hello.
Yes, you are audible.
Thank you, Dr. Moin. Good evening, everyone, and welcome to the question answer session of webinar titled Colonic Anastomoses, Existing Practices and New Trends. I am Dr. Adnan Bacha. I will be moderating you through this session. I would like to express my heartfelt gratitude to Professor Dr. Sanaullah Shali, chairperson of this webinar, for giving me this opportunity and arranging such an informative topic for the discussion. Glory of medicine is that it is constantly moving forward and that there is always more to learn. I thank all our learned speakers for enlightening us this evening with the words of wisdom and effectively keeping us glued to our chairs. We are lucky to have very renowned and esteemed panel of experts with us. Active participation of audience will be highly appreciated. They may drop their questions in the QA box. While we are awaiting for the questions to come in from our audience, let us start our question and answer session.
Can I ask a question to Dr. Matthews, please?
Yeah, please, yeah.
Yes, sir.
Matthews, hi. So we have been doing now robotic low anterior section for last 2 years. And the challenge which I face in some of the cases is that, bulky tumor in the narrow pelvis, it is difficult to manipulate robotically. You can't pull it up. So, on of occasions, I have to convert robotic to laparoscopy to pull the tumor up.
Okay.
Do you face the similar challenges, or there is any trick to manage it?
I think if you're, whether you convert to laparoscopy, can you hear me?
Yes.
Okay.
Yes.
Whether if you're going to change a robot, if you find a difficult rectum in a thing, whether you're going to change to laparoscopy is going to be sometimes even more difficult because the space now and open also may be same. But if it is to do with the retraction, I constantly use, it depends on whether you do a sequential dissection low down so that it can be able to pull up little at a time rather than just do fully posterior, then right, then left, then anterior. So if you do sequentially, the more will come out, but posterior is the most, then it can come out more. Second thing is once I reach the upper rectum or mid rectum, if I find it difficulty, I do a nylon tape and I use that to pull it out. The third thing is the port placement. The port placement makes a huge difference to how you're going to be able to manipulate this. And the very last thing is that I have an assistant port. When I redock for my pelvis, the assistant can pull up the rectum as well. So in addition to the 3 arms I have, the assistant will be on one hand will be the sucker and the other hand will be the pulling the rectum. So with this, I think it is superior than the laparoscope. So I think if you do these, I think I haven't needed to convert. The only time I needed to convert is that if there is a additional injury or because the tactile feedback is not there where I need to really feel or residual tumor, etc. But I find that these helps. And obviously, if it's a big bulky rectal cancer, the neoadjuvant therapy sometimes helps if it is indicated. It shrinks the tumor, but obviously makes the operation a bit more challenging.
Yeah, so obviously I think it is the bad habit of 25 years doing laparoscopy, which probably
I think it is I think it is that it was possibly that because your people are very comfortable, but I think if it's a question of changing slightly the things, and then I think it is okay.
Yeah.
If I may interject between the two gentlemen.
Yes, Sarfaraz.
I think for any bulky tumor inside the abdomen, I so love much my hand inside the abdomen. Of course, that's just an opinion because the disclosure is I don't do robotic surgery. I do laparoscopic, but even compared to laparoscopy, if I see a bulky right iliac fossa tumor, if I see a bulky rectosigmoid, I personally am happier having my hand inside.
Yeah.
But that's because I don't do robotics.
Yeah.
Okay. I think I can see a question for me in the chat box. So if you, with the permission, can I answer that question?
Yes, sir.
Yes, sir.
You can answer.
Yeah. So there's a question about the large mesocolic window. Why does it need to be closed? Well, the standard teaching is to close all mesenteric defects, whether it's GI surgery, bariatric surgery, whatever surgery we do. In a right colectomy, yes, there is a huge lobby which says that we don't need to close it. It's so huge. What is it going to happen anyways? It's such a huge area. And true, we did not close it for almost a decade of doing this. Till in 2017-18, we had one obstruction in that window. And then we decided to change our policy. So now in the last 3 years, whenever it can be closed, we close it. And I think at times it is at times it looks much better when you close it. You feel far more secure. So no hard evidence out there. It's just something that you believe on the basis of what we already know from other standard literature, and something that you have in your own experience. So all of us, we change based on what our experience is.
Thank you, sir. I guess there is another question in the chat box for Dr. Deep Goyal.
Sorry, I missed it. What is it?
Sir, the question is directed, I guess, to you. It is excellent presentation. What is the definite demarcation of late T2?
So what I means by late or early T2 or T3 is an ugly tumor, where there's a tumor biology which is not favorable. Though classically, if you go by the T1, T2, it falls into the category of T2, but it's a bad tumor biology, where you can, argue whether you still like to treat it as a T2 lesion or a T3 lesion. So in the countries where there's a clear-cut demarcation, like in US, where T3 tumor will receive neoadjuvant treatment and T2 tumor will receive direct upfront surgery. And in UK, even a good T3 tumor will go for surgery upfront. So there is a demarcation. If a good tumor biology, T3 lesion, I would still do a upfront surgery. A T2 lesion with a bad tumor biology, maybe I will give a neoadjuvant treatment.
Thank you, sir. Sir, I would like our panel of experts, if they have any questions. Shahadat sir, if they have any questions, they can ask to our learned speakers.
You mean Shahadat Hussain or Shahadat Hussain Sheikh?
Sir, Sheikh, sir.
Okay. Thank you. Thank you, Adnan.
Thank you, sir.
And the chairman of the session and all the speakers, their presentations were excellent. And thank you. Congratulations, all the speakers. Deep Goyal.
Thank you, Roshan.
Okay. And the Ronnie Matthews.
Thank you.
Thank you. For us. Yeah.
Thank you, sir.
So the thing is that probably the main topic was about the colonic anastomosis. So anyway, by this time we have learned many things about not only the confined with the colonic anastomosis, but at the same time the right colonic dissection technique and the robotic technique from the Ronnie Matthews. I'd like to comment something about the anastomotic leakage. Actually, unfortunately, we do not know why most of the cases anastomotic leak occurs. So very difficult to prevent the anastomotic leakage, because this is not the only factor, the technical issue of the surgeon, because patient's factor, hospital factor, operation theater factor, even the quality of the instrument factors. So a lot of factors are there at the to prevent the anastomotic leak. And currently, we know everybody probably the microbiome, the alteration of the microbiome is very important issue nowadays, in discussing everywhere. So microbiome become converted into the pathobiome. So that is another issue we have to consider for the anastomotic leakage. So anyway, if I come to Sarfaraz about your presentation. So you currently probably are practicing the intercorporeal anastomosis in case of right hemicolectomy, so far I understand from your presentation. But whenever you go for the extracorporeal anastomosis, so what technique do you follow? Do you feel the intersection of the staple line is a problem for the anastomotic leak? So what is your practice?
Yes, sir. So that's a very good, sir, question. I must say that the extracorporeal anastomosis is probably something that most surgeons still practice, and few centers have probably migrated into intracorporeal. So extracorporeal anastomosis is the most important thing. The first thing to decide is where to put the incision. If the incision is placed away from the colon, then it will become difficult. So the incision has to be on the colon itself, where the colon has been intersected, which would mean it has to be either at the supraumbilical region, or it may be a right upper transverse incision. If one fails there and one thinks that I will put it closer to the ileum, or I'll put it infraumbilical because that's cosmetically better, and I'll somehow drag the colon, that's the first mistake that we used to make, and I think that mistake should not be made. The mistake, the ileum will go anywhere. It is mobile. The colon will not give the liberty of going anywhere. So first thing is plan the incision right on top of the mid-transverse colon, where we have to do the anastomosis. So that's number one. Number two, make a larger incision large enough to extract the specimen. But ensure that one stapler has been fired inside the abdomen so that we can take out the ileum separately with hanging on a thread, but the colon comes as one specimen. Now, why I'm saying this is most of us try to take out as a loop with two bowel ends coming out. That would increase the incision of the extracorporeal anastomosis. Make sure one stapler has been fired at the ileum level, and the ileum has been stitched with a thread, so one can catch the thread of that ileum, and the other end of the ileum would drag the entire colon with the tumor outside. That would reduce the incision. That's number two trick. Third trick, when the incision is big enough, it will not occlude the vascularity of the two bowel ends. If the incision is small, one may finish with the anastomosis and then you find it has all become blue and black. Now, that would be a disaster. So having a large incision both at the skin and the sheath level is important. And finally, yes, intersection of staples are important. Our practice is to have a side-to-side anastomosis. So we staple two ends, that's one ileum, which has already been done intracorporeally, and the colon, and then a side-to-side anastomosis, which could be totally sutured, or it could be a staple with suture closure of the enterotomy. So there is hardly any crossover of the staple line. Thank you, sir. Sir, you are on a mute.
Very good tips. Thank you very much, sir. I think you always try to avoid the Barcelona technique.
Yes, sir.
Where the intersection is always happening. So thank you very much. Now, Professor Deep Goel. So your presentation about the rectal cancer, everything is nice. Probably you have covered many things. One issue about the double stapling anastomosis in the rectal cancer. So you know, the TATME comes to mainly to avoid this double stapling, so that they go for the double pasting and single stapler. So what is your current practice? Do you know about what currently doing the anterior spinally, the TTSS, another technique? He tries to avoid the transverse stapler, so that he avoid just two stapling. Another actually he tries to avoid the dog ear. That is the weak point of the rectal anastomosis. So what is your comment about this issue, the double stapling or the double passing single stapling anastomosis? Professor Deep, go ahead.
Deep, you are on a mute. Deep, you are
Deep,
on a
you have
mute.
to unmute. Deep, you have to unmute.
Sorry, yeah.
Okay.
Okay. So I have no experience with double pulse string technique. What we use a double stapling technique. And if you have mobilized the rectum well enough and there is enough space in the pelvis to fire the stapler, you can most of the times avoid the dog ears. If the pelvis is narrow, what we do is we use a 45 millimeter cartridge rather than a 60 millimeter cartridge. We may end up using 2 cartridges in low rectal cancer. That is fine, but that avoids the dog ear. Dog ear basically happens when you are slanting your stapler and not firing it perpendicular to the tumor.
But most of the time, if you use the 45 millimeter cartridge laparoscopically, so most of the time 2 stapler is required.
Yes.
2 staplers. So the 2 stapler, when it is required, it is very difficult to incorporate within the head of the circular stapler to make out this total staple line. So there should be at least one side or 2 sides, there should be a dog ear.
Well, technically yes, but practically no.
Okay.
That's the genuine answer. Technically yes, but
Yeah,
practically no. You see, you learn with experience how to avoid a dog ear. And when you are firing a circular stapler, it should come out in between the gap. And it is possible. So the biggest mistake which we make is that the person who fires the stapler from below is the junior most person most of the times, because you are at the top end. So if there is a specialized experienced person firing the circular stapler from below, all these problems can be avoided.
Okay, so do you like to go for this staple push and then pull so that area will be loose and you can push all this staple line into the head of the circular stapler? But
absolutely,
but it should be at least 33 or 31 staple. Otherwise, it's not possible to introduce into the 29 stapler.
31, yes, most of the time.
At least 31, you can try for that. Okay, and after that, probably you routinely go for the air leak test in every cases.
We do perioperative endoscopy and leak tests in all the cases.
But most important thing is the air leak test.
Probably
you agree with that. And when it is
but our decision of doing a diverting stoma does not depend upon the leak test.
Okay, but in some cases, when you did not plan for the diversion, but air leak test is positive, what you do actually in your practical experience?
That's what I'm saying. When we are talking about low rectal cancer, I would say more than 90% of our cases have received neoadjuvant treatment, and all of them will undergo a stoma. All of them will undergo a stoma. But yes, I take your point. In case you have not planned, I mean, there obviously cannot be a case where you have not counseled the patient that there is a possibility of having a low rectal cancer. But yes, you would like to avoid it. But if the leak test is positive, that patient, in spite of repairing that leak, I would still do a stoma.
Okay, that's your practice. Okay. So, Ronnie Matthews, so your presentation about the mostly on the robotic but congratulations and thank you very much for all the honest opinion about this robotic and laparoscopy and everything.
Thank you.
I appreciate your presentation. So one thing, do you always use your ICG in every anastomosis in your practice?
Okay, ICG in our hospital, no, and there are some indications to use. I think that is a more logistics and you have to purchase a stack and all these things. I think personally, this is just a personal opinion. I think ICG is very good. And it is a good thing, but a few things for ICG. One, you need a stack. Second, it changes and it's improving. The striker comes out, Carlsos come out, Olympus come out. So it depends on what. Then stack and this and how much to give, when to give. But sometimes if you're not careful, you can get into a false sense of security. It is all okay. ICG, sometimes it doesn't, because my own personal technique is I check for the marginal all the time. I do extracorporeal, let's say rectum, take it out, check for the marginal if I don't cut back. So I'm not worried about the mucosal ischemia at all. Now, even if the marginal is good, I still check for the mucosa cuttage and the bleeding and the color inside. And with a check endoscopy at the end, the ICG will not show, in my opinion, very small effects of mucosal ischemia. The problem will come, if there is some leak or some cardiac issue, etc., then becomes more problem. So ICG has an issue in the sense that it is good adjunct, but people get into a false sense of security. Secondly, the stack and issues like that is there. So and it is not only the blood flow, it is also the tension. To me, the two most important thing is the tension and the blood flow. So sometimes you think ICG is okay, it's done, that is it. So I still feel, and I feel there's a particular use of ICGs in the minimally invasive, because sometimes you want to do everything intracorporeally, then you can't see all these things margin, and then it's useful. But I feel that before rectum, we are talking about rectum, you anyway need to take the specimen out, you have to put up a purse string and anvil, etc. So I'm not particularly worried, and I don't use it, but if given a choice, I'll use it selectively if I'm needed, but I still rely clinically.
Okay.
Can I make a comment, Dr. Shahid Sheikh?
Yeah, of course.
Okay, so I would agree with Dr. Matthews that it is very useful technique, but my criticism is, if it is not very simple, you need to train your eye to recognize how ICG is working. If you do not use it regularly in every case, then when it is required, you are not experienced enough to interpret what the result is. So in robotic surgery, most of the time, since it is inbuilt, we use it in all the cases. But yes, sometimes when you're doing laparoscopic cases, sometimes that equipment is not available or somebody else is using it. So obviously we don't use it. But in robotic surgery, we use it in all cases. And it is better to use in all cases because that is how you will train your eye to interpret it.
Okay, probably you showed that data, the ICG group and non-ICG group, there's a huge difference of the anastomotic lead.
Yeah.
In Bangladesh, we are practicing, we don't use ICG. We are just depending on our clinical eye. That is the time-honored, detention-free, well-vascularized anastomosis. But thinking about the ICG, because we are going through a lot of data, the ICG group is better, there is better anastomotic technique, and you can be more secure. So you not all cases you are not practicing in ICG, right?
We are practicing in all cases when we're doing robotic. In laparoscopic, depending upon the equipment, if we are able to get the equipment, we do it. If obviously we do not have equipment, we avoid it.
Okay. So thank you very much. Thank you, Ronnie Matthew, for your wonderful presentation. Thank you.
Dr. Adnan, please unmute.
There are some questions which have been collected from our study group. I would like to share those questions with you.
Okay, immediately you start. We're running out of time. Okay, as your earliest. Can you hear me quickly, please?
Yes, sir.
Okay.
Sir, as discussed by Professor Sarfaraz, he has mentioned in his topic that the anastomosis they make is isoperistaltic. Is there any problem if intercorporeal anastomosis is done antiperistaltic?
No. So as I mentioned, there is absolutely no difference as per literature on this. It is just what looks better for us. So we try to place the colon and the ileum like this, in an isoperistaltic manner, and then the mesenteric closure also becomes easier. So it's just about a technical point. It has nothing to do with leak rates. One can practice either, doesn't matter.
Okay, thank you, sir.
Quick.
Sir, raised BMI is an important factor while operating laparoscopically. At what BMI do we feel comfortable to do right hemicolectomy, and why?
I'll reverse that question for you. I feel comfortable doing right hemicolectomy laparoscopically all the time, but it wouldn't make a difference if it was a thin patient. A thin patient, right hemicolectomy, open and lap would probably not make a difference. It's actually the benefits of laparoscopy becomes paramount when the patient has a higher and higher BMI. At what BMI? Well, doesn't matter. If it is 30, 40, 50, 60, 70, 80, it won't matter. It would matter if the BMI was 20, then it doesn't make a difference whether I do it laparoscopically or open. So that's the answer for your question.
Thank you, sir. Sir, another type of anastomosis is side to end staple anastomosis. Are there any benefits of using this type of anastomosis? Sir, this question, I guess Dr. Deep Goyal, if he will answer, it will be better.
Well, I have no experience of side-to-head anastomosis. 100% of cases we do side-to-side anastomosis in colonic surgeries, but in rectal surgery, obviously side-to-end is something what we do, and there is evidence in literature that end-to-side anastomosis is called J pouch, we can call it, has better results initially, but otherwise at the end of 2 years, all kinds of anastomosis have similar results. But as far as colonic anastomosis is concerned, our 100% anastomosis are side to side.
Can I add something, Adnan?
Yes, sir. Yes, sir. Please.
So, no, in your question in literature, if you follow the ASCRS last publication, so they showed there is basically no difference in terms of anastomotic leak.
Okay, thank you, sir.
Just a question, Adnan, how will we do colonic end-to-side anastomosis?
Probably he asked about the ilocolic anastomosis.
Ilocolic, sir.
Okay.
Sir, not in case of rectum. It was for right hemicolic. Ilocolic, sorry. Sir, if the leak happens in the right anterior resection without ileostomy coverage, what immediate steps can be taken in order to save our patient after in recovery room?
No, it depends upon what is the presentation of the patient of a leak. If it is a localized perineal leakage in rectal cancer, then maybe you need to drain that patient either by imaging, putting a drain, or just aspiration. If patient is in sepsis or has a peritonitis, obviously would require a diagnostic laparoscopy, peritoneal lavage. And if there was no stoma, maybe you need to divert the patient and drain the patient properly.
Dr. Adnan.
Sir.
I'm interrupting. I think Professor Marco Busen sir is here. I think he will add something in this topic. Leakage, if leakage happens in anterior resection without ileostomy coverage. Marco Busen sir.
When I think other two panel of experts are there.
Yeah, stop the share screen. Share screen to stop.
Dr. Adnan, please stop your share screen. I think.
Am I audible now?
Yes, sir. Now you are audible.
Thank you very much for asking this question. Actually, I was enjoying all the deliberations, and it was something dream for me, because when I started my life as a student, I saw the first case when I was in third year in 1974. Then everything was something blind. Everybody will know it then.
Sir, I want to just 1 minute, sir. Sarfraz Jalil Beg will be leaving. He has got another meeting. We are listening to you, all of us, and he has done a good job. Thank you very much, Sarfraz, coming here, and again we will be inviting you. Okay. Sarfraz leaving. We'll be here. Sir, you continue.
Okay. For the question that has been raised, actually, when there is leakage after anterior resection, without doing any colostomy
coverage.
we usually open it up and see whether the leakage is here, and then we do a colostomy so that anastomosis will be here. If the leakage is not too much, even then, I think I will go for a diversion colostomy so that wound will heal, and then we will repair it again. That is what is in my Thank you very much. The basic principles remain same. If there is an anastomotic leakage without doing a proximal diversion colostomy, you do it then again, because you have not done it before.
Yes, sir. Sir, actually, we are almost doing same thing what you did in 1974. Almost, we are very close to that.
Yes, the basic principles are the same.
Yes, sir. Yes, sir.
Thank you, sir, Professor Margobushan, sir. Actually, we all the audience were very eager to hear something from you. Now, Professor S.M. Ashraf Ali, sir. Sir, please, Professor S.M. Ashraf Ali, sir. Sir, please, can you add something about this topic? Would you like to add something?
Thank you very much. Am I audible and visible?
Yes, sir. Clear.
At the very outset, I must express my gratitude and heartfelt thanks to the Society of Surgeons of Bangladesh Chittagong branch and its president, Professor Sanaullah, and Secretary Mainuddin. Heartiest Zoom digital welcome to Bangladesh to all three speakers. You know, due to COVID pandemic, we are unable to offer all the speakers to come to Bangladesh, but we are expecting that very soon the pandemic will be overcome and all Deep Goel and Sharfaraz. So I know them personally. I'm totally agreed with the first speaker that nowadays there is a choice to do all the anastomosis intercorporeally, undoubtedly. There is no doubt. But one thing is that it must be done by an expert hand, and particularly Professor Deep Goel stressed that a good team is must. What is shown by the Deep Goel that particularly in the early 90s, there are a lot of shortcomings. There's the long times, the leakage, complication, cause bleedings. But I'm sure that in course of last couple of decades, we have successfully overcome all those don't jump to do it. It is not possible to beat Dev Goyal in a 1 year or 2 years. Or like Ronnie.
Thank you, sir. Now we will hear something from Dr. Mohammad Nur Hussain Bhuiya, sir.
Thank you very much, Dr. Moinuddin Mahmood. Thank you, organizer, Professor Dr. Mohammad Sanullah Sheli, respected speaker, honorable panel of experts, my teacher, Professor Margo Hussain, also the Professor Asam Aktafali, sir. And I was also go through the whole of the session. And the first speaker, Shortforest Beck, said about the colonic anastomosis. I think whatever the procedure, intercorporeal or extracorporeal, it is continuous or interrupted, but basic, I agree with the Professor Margosan, sir, the basic principle of, if you follow the basic principle of anastomosis, then the leakage may be decreased in case of anastomosis. But we follow the basic principle of anastomosis. That means the use of suture material, the vascularity of the both end, whatever the side to end to side, or side to side, whatever the procedure, if we follow the basic principle, it may be the chance of leakage is decreased. The next second speaker, the Deep Goyal, said about the low rectal cancer, the difficulties. It is actually it is early late T2 and early T3. In these cases, it is curable or not, and whether we go to the oncology first or the surgery first, it is actually till now it is debatable. Somebody says it is do surgery first, then go for chemoradiation. Somebody says the oncology clearance first, then oncology first, then go for surgery. But whatever it is, the low rectal resection, if we clear the 2 centimeter margin in according to the goal after the chemotherapy, as the Luan is shrinkage, and then 1 centimeter clear is preferable, then it is safe for the colonic anastomosis. And lastly, robotic surgery. As we have or I have no experience about the only robotic surgery, only the video experience of the robotic surgery. Nowadays also the Zoom experience of the robotic surgery. So it is actually I don't know about the difficulties or technical difficulties uh, or technical difference between the laparoscopic surgery or the robotic surgery in case of low rectal cancer. Which one may be the better procedure, or which, whether robotic or whether the laparoscopic one is the better procedure. As we oriented about with the laparoscopic procedure, till now we think that the laparoscopy also the available all over the world. So the till now it is continued the laparoscopic procedure. So I don't know what about the advantage of the robotic procedure in low rectal cancer. So even then, I must give thanks to all of the three speakers for their very excellent presentation, and all the panel discussion with the Professor Sadat Hossain Sheikh, also with the panel of speaker and all the audience. Thank you very much for listening to me. Thank you very much.
Thank you, Dr. Nurusen Bhuiyan. Actually, we can say that uh, leakage, anastomotic leakage will be decreased, but it will not be zero. Now we'll hear something from Sadat Hossain Sheikh sir. Will you say something?
Sadat Hossain.
Sheikh sir. Okay. Now we'll hear something from
Professor Sadat, Chairman,
Professor Mohammad Sadat Hossain sir.
He's the
Chairman, BSMMB, colorectal surgery, Bangabandhu Sheikh Mujib Medical University. Sir, please.
Thank you very much. Particularly, I give thanks to Professor Sanaullah Seli for arranging such a beautiful webinar. And that is our opportunity to continue our exercise even in the era of COVID-19. That is an opportunity to listen to all the papers, which are very beautiful papers. And particularly that I want to extend my thanks to Dr. Sarfaraj, Dr. Deep Gale, and Dr. Matthew. All these three papers are very beautiful and excellent, and very much, I think I would say that it's a very, at the end, very much beneficial to the audience. I thanks to all the panelists as well the participants. Very important thing I want to make a comment about the leakage. The leakage is so important, you know. Most important to think that particularly in the low rectal carcinoma, the anastomotic leakage, you will see the patient after in the post-operative period, you will see the patient is doing fine. He's all right. His appetite is good. He has no fever. He's improving. Even the patient may have passed flatus. Suddenly, you will see the patient is saying that he feels unwell. Heaviness in the abdomen. Loss of appetite. Sometimes with nausea. Sometimes fever, and we'll see the tachycardia. It is the doubt in your mind, the clinician, that what may happen. That is the thing you shall have to detect it early. And earliest possible detection can save the life. If you delay it, if the first, then really it is difficult to save the patient. So once you have the doubt, you do the clinical assessment properly, you do the biochemical tests, all the hematological tests. Most important of all is to determine at that level is to do a CT scan. And that will give you the clue and take the decision early so that you can save the patient. And the steps are the same that you shall have to explore most of the time. And you shall have to convert it to a diversion. And in that way, you would wash the abdomen, you do the lavage and put a drain. These measures can save the patient. So it is the early detection of leakage that is most important in case of the management of leakage case. Thank you all for giving me the opportunity to add a few points. Thank you very much.
Thank you, Professor Mohammad Sadat Hossain sir. Now, the chairperson of this session, Professor Mohammad Sanaullah Seli, will hear something from you, and he will conclude the session.
Most welcome, my dear friends from abroad and also from my country. Such a wonderful gathering and such wonderful speeches from all of you, naming the Deep Goel, Ronnie Matthews, and Sarfaraz. But I have to say a few things because of my country, the reality, and what we are doing now to some extent. What will be the take-home message? Already it has been said by Sarfaraz for his right hemicolectomy that we need to do intracorporeal anastomosis. Okay, if this operation is being done laparoscopic, so laparoscopical operation to be anastomosis as intracorporeal. And there is some improvement in it, obviously, no doubt about it. But at the same time, we want to know that at the same time, 100 years, that end-to-end anastomosis and open operation didn't change and didn't change its leak rate. But at the same time, you are coming to a new era of intracorporeal anastomosis, and some of the good centers and lots of good surgeons are doing intracorporeal anastomosis. Definitely leak rate is less, undoubtedly, than this open end-to-end anastomosis. It has been proven by so many of the studies, and these are all RCTs. And a lot of RCTs are mentioned by Deep Goel. And at that time, I can remember 2002-3, the first color study, no rectum, classic study, no rectum, and cost no rectum. Then comes the rectum and comes and comes. So we don't want to tell it. But one thing is that it is good intercorporeal anastomosis, but not for all cases. It could be if you face problem, you come out. Sarfraz said that he can do as a bariatric surgeon for any BMI. But I say all the literatures are coming with a BMI 35, more than 35. You need a more efficient surgeon. I think a bariatric Deep Goel is here. But other surgeons should not try laparoscopically. These are the all studies till now supporting the BMI should be around 35, not above 40 or super obese. They don't go for hemicolectomy with laparoscopic and corporeal anastomosis. You might face something. There come Ronnie Matthews, there come Deep Goel with some, whether they can help. And there is some study that they can help with the robotics. Yes, of course. So the take-home message, please train yourself if possible and establish yourself as a surgeon who can do intracorporeal anastomosis. Next thing is training. And another very important point mentioned by Deep Goel, that teamwork. Without teamwork, another surgeon near to you should be with you. It's my saying. Another surgeon near to you should be with you. Because if you are in trouble, who will rescue you? Ask another surgeon from another hospital. No. I don't say this opinion is no more valid today. You make another surgeon near to you so he can help you. That should be the more appropriate thing in any institution to be done. And our most important another thing about the Goel indocyanine. Okay, a lot of studies are in favor. I support, though we are not doing, if we possible, as Shahadat also said, if possible, we can practice the indocyanine game to some extent. It is proving that the leak rate is less. So many studies, I don't want to mention the studies. But again, one really troublesome thing for Bangladeshi patients is a radio and chemo radio followed by almost nil tumor, and then whether follow-up CCR, patients are not following us. So how can we go for CCR? What will be our answer for CCR? I don't know. Patient is not following us, but still we are convinced, much more convinced with the oncologist that okay, you see, we can do so if the patient is very much compliant to the surgeon, and that will be one very important point. Right hemicolectomy steps are not 4 or 6; it is nowadays 10. What said by actually Sarfaraz. Okay. Now another thing, one thing I said, some studies are in favor of robotics in rectum. Rectum is really, it is still not out of confusion. What is the best one to be done? It is not out of confusion. So I ask for the south part of this Asia, all of 3 countries people are here. Our patients, can we do something RCT for this? Our patients, what could be the best option for our patient? Looking at the model of other studies, we can also do. We can start as say for two Sheikh, two Shahadat is here, BSMM is here. Deep Goel is there having a very big hospital. Ronnie Matthews is there. That is also the biggest hospital once in Singapore. I don't know it's now any other hospital is biggest than now. So I think a study for our people I think we can do something. I think we can do something and think about it. Think networking among us. Think networking among what you are finding, what you are getting. Let us inform each other and let us improve. Let us inform, let us improve. Let us show our problem and you will give. So these discussions are more beneficial for the surgeons when you will tell I am facing this problem and this could be solved like this. And I'll show you, I'm not talking much about it. I'll show you one picture. One picture, it's my own patient. And you see this picture and this will be I think, a good memory for you to take home. And okay, just follow this picture. This is actually a right hemicolectomy done. Why done? Why done? I am going to next picture. You see, this patient has got, if you can follow, there are some polyps. You can see this is ileum having 2 stones. Actually, it was not found, but the colonoscopy showed there are some polyps, and then dysplasia came, and I agreed to go for right hemicolectomy, open side-to-side anastomosis with the stapler, and then you see the stones came in the patient had got pain sometimes, and these are the 3 stones, and this is the ileum, and again these stones, and you see now very interestingly showing these polyps in the cecum. So now what is my talk about it? I will come to back, okay? And so I can remember just one thing Shahadat was telling, and it was really screen is no, come to screen share, come to screen share. Okay, I was remembering one thing Shahadat was saying. What is the microbes? What is the microbes? What is the chemicals? These are the stones in the small gut, and his gallbladder is fine. So, and then I searched the papers all over the world. A few papers said they are getting the small gut stones, and these are the small gut stones. So what the South people, our country people eat, and what the biochemical events are going on, microbial things are going on. Why our country is developing this type of stone, though it is very rarely. I think again there are some points in the leak rate for the microbes and other biochemical events also could be proven late in the decades we are waiting for. So thank you very much. Think about the stones I have shown to you. These are all small gut stones. Thank you very much for coming with us. Do you want to say anything, Shahadat? Do you want anybody? Please. Yes,
I want to make some comment, a little bit one.
Yes.
Often
Yes.
we talk about the piccolith when it is in the case of the appendix. When it is in the case of the appendix, we call it piccolith. Lith means stone, you know.
Yeah, of course. But that is small, very small. Small.
If it is in the
big
appendix,
stone. No,
if it is in the appendix, why it is not possible to form it in the gut?
Yeah,
other part of the gut.
Possible, but the lumen is big, and the ileocecal the valve is definitely ileocecal valve is patent. I think ileocecal valve is patent. So anyway, Deep was trying to say something. Okay, it's not over.
No. I was just saying I'm fine. Nothing.
So we can conclude our session, sir. Sir, anything, sir? Professor Marguf Hussain, sir, you want to say anything more? I think he's not hearing it.
Stones in I've not seen that stones here, but I've got some cases of what we call this
stone in the small intestine. Small stone in the small intestine.
No, I've not seen such a small stone in that here. Rather, I have got two or three cases.
Thank you, sir. These are big stones. These are big stones I have shown. Patient was presenting with subacute intestinal obstruction. Colonoscopy showed the polyps, and that was the histopathology. And I again say the point of Deep Goel and Matthews about the pathology of the stages 2 to 3. the pathology is very important till now to make a decision. So thank you very much. Thank you all for coming to say us something, and we'll learn from you. And in future also we'll learn from you. Thank you very much.
Thank you very much. Thank you, everybody.
Thank
Stay
you.
safe.
Yeah. Bye-bye.
No, thank you.
Stay safe. Thank you.
Okay. Okay, Shadat, thank you very much. Where is another Shadat? He is missing. Okay, no problem. Sir, thank you very
You are watching Raj TV, Jagorone, Bangladesh.